So you may wonder why I am starting my lecture with this beautiful Delftware, Royal Dutch Delftware cup. So the Delft blue, as we call it, the paint is just to give this evening a bit more of a Dutch touch. But the material this cup is made of is actually very relevant for the field of regenerative medicine. But I'll come back to that later, and you will also be able to experience it yourself. But before I do that, I would like to introduce the phenomenon of regeneration, and also to explain why we need regenerative medicine. Many of you will know that a newt, a salamander, they are very special animals because they have an excellent regenerative potential. You can see that in these images. If a newt loses a limb for whatever reason, all it has to do is just wait, and a new limb will grow. So in this case, you see about 140 days later, the new limb is there. And it does not only look the same as the original one, but it is as functional. And we did not have to interfere, and the animal didn't have to do anything. And the funny thing is that the newt can do this with a limb, but it can also do it with an eye or any other organ in the body. Well, we cannot do this, unfortunately. If we lose a leg, regardless of how long we wait, we will not get a new one. But that does not mean that we do not possess a regenerative potential. We actually do. Because that is what regeneration is the ability of the body to repair, to regenerate, and to repair itself, to repair a defect, and regain a function, a normal function again. So people have regenerative potential too. Think of a small accident in the kitchen. When you cut something, you cut yourself in a finger. What will happen is that the finger will start bleeding for a couple of minutes, and then the bleeding will stop, and usually 4 or 5 days later, you will not even be able to show where the cut was. And this is a beautiful example of a regenerative potential of a human body, so of our skin, to regenerate, to repair a defect. Another example is a child that falls and breaks a leg. So all we have to do is to fix it into a cast for a few weeks, and then later on the x-rays, the surgeon or the doctor will probably not be able to even show where the fracture was. So we do possess a regenerative potential. But then why do we need regenerative medicine? The reason is that our potential is insufficient when a defect becomes large. So when it becomes too complex, then our natural regenerative potential fails. And giving examples from the regeneration or large bone defects, think of trauma. So think, for example, of a severe car accident where there is not a small fracture of a child falling down, but it can also be, for example, that there are very large pieces of bone missing. Another example would be a bone tumor. Very often the tumors, as patients who have a breast or a lung tumor, these tumors actually move to a bone. And the surgeon will then have to remove pieces of bone, making sure that there are no tumor cancer cells left. And the surgeon wants to be very sure that there are no cancer cells left. That means that a lot of tissue has to be removed, a lot of bone has to be removed. And then the patient is left with a very large defect that cannot repair, cannot regenerate unless we interfere. And that is what we mean with regenerative medicine. Now we are looking for something that will help the body to stimulate the regenerative potential and close the defect. So what happens in 9 out of 10 cases is that this patient who comes to the hospital, the surgeon will take pieces of bone elsewhere from the body, for example, very often from a hip or from a chin, and transplant it to a defect area. That is the best, the golden standard right now. And this is quite efficient. However, there are a number of disadvantages associated with this treatment. The first one, complications in a number of cases. Then the pain. Actually, in almost 40% of the patients, they will experience pain even 10 years after the treatment. And not in the original defect area, but actually in the area where bone has been harvested, removed from. Of course, the problem is that we need 2 surgeries, one to remove bone and one to transplant it. But the most importantly, the limited availability. There is only so much bone that we can remove without long-term negative effects. So there is only a certain volume of bone that we can remove to transplant without having long-term negative effects. And this is an issue if the defect is really large and complex. But this is becoming actually a much larger problem as we age. So our Western population is aging, we are getting older. And we are not only getting older, but we also would like to stay active and mobile until the age of 85, 90. And with that, the chances of new defects, so new fractures, new accidents are increasing. Moreover, as we age, our regenerative potential is actually becoming less strong. So there are 2 problems. The chances of new defects are increasing, and we cannot regenerate so well. And then there is actually a shortage of our own tissue that we can use to repair a defect. So once I told this story to a famous Dutch cartoon maker in the Netherlands, and the next day he sent me this cartoon. He said, well, you are a great scientist, right? So this is the best you can do. You can just, the golden standard in your field is to repair one defect by creating another. And this, of course, is something that we do not want to accept as a scientist. And that is why the field has been working on ways to find an alternative for a patient's own tissue, for a patient's own bone, for example. So now, coming back to my cup. Why this cup is similar or important for the field of regenerative medicine, it is because of the material it is made of, and that is a ceramic. A ceramic material that is made in a very similar way as a cup. So you have a powder, you mix it with something and you bake it. That's pretty much the same process as the materials that we use in regenerative medicine for bone regeneration. Although the chemical composition of the cup is different from the chemical composition of the ceramic we use in regenerative medicine. Because, can I have the visual, please? Maybe they will. So here, and you will also somebody will give you, you can open what you will get, you can open it, you can remove a particle from there, you can touch it, because that is what you also see here. This little, okay, can we go back to the presentation, please? That is the type of material that we have developed for regenerative medicine, for regeneration of bone defects, in order to replace a patient's own bone. Now, these ceramic particles, they have a chemical composition that is very similar to what is found in a natural bone. So a bone from a materials perspective, I'm a materials scientist, from a materials perspective, a bone is a composite material. It consists of a ceramic and a polymer, a plastic. So it's a combination of the 2. And the ceramic particles that you get distributed, that you are able to touch, they actually have the chemical composition that is very similar to a mineral, so ceramic portion of a natural bone. And because of that, these particular ceramics that you will be able to touch, we have developed them such that they have the chemical composition, but also the structure, that they are able to give the body the right signals that new bone has to form inside the body. So basically, you can take those particles, you can place them into a defect area, and they have the composition that is such that they can instruct the body to start producing new bone in order to close the defect. So actually, again, the way to enhance the regenerative potential of the body. So because that is also exactly what happens in the newt, in the very beginning. In a stump where the limb is missing, there is a very complex set of signals that initiates the process of regeneration and tells the body you have to create a new limb. And that is comparable to the materials we have here. They can instruct the surrounding of the body to create new bone, And once that is the case, once the defect is closed, the material will disappear. It will dissolve. And that is exactly what regenerative medicine is. It is not passively taking over a function of the body. It is not a permanent hip implant that takes over the role of a natural hip, but it is stimulating the body to make its own hip. It's stimulating the body to make its own bone. Now, so this is what is special about these materials here is that they are also very simple. They are, I'm giving them to you. You can keep one particle if you need one, or you may need one in the future, because we can produce them in large amounts. And they can be inexpensive, and they are off the shelf available. So basically, instead of relying on the amount of tissue that the surgeon can remove from the hip, that when the patient arrives to the hospital, the surgeon can just take it off the shelf and use it when needed. So now you may think that regenerative medicine is particularly important for elderly patients, but that is really not true. And I will show that based on an animation that shows the development of colleagues of mine at the University of Technology in Eindhoven. So what they have done here is exactly the same what we've done for a bone, but for recreating heart valves, malfunctioning heart valves, in particular in pediatric patients, so in children with congenital disorders. So when they are born, they have a heart valve that does not open and close properly. So what they have done is to develop a material that, in terms of many properties, very much looks like a patient's own heart valve. But then, when it is implanted, it is able to attract the cells from the surrounding and instruct them to create a new heart valve tissue, after which this material will disappear again. So again, the idea is pretty much the same. Temporarily offering something to the body to initiate, to start the process of regeneration, and then disappearing. So again, not passively taking over the function of the body, but just instructing the body to create its own tissue. So we can do that here. So they've used a polymer, again, a plastic that has certain properties. They have electrospun it. They have made a mesh of it to create an environment that very much looks like the environment for the cells. It looks very much like the environment of a natural tissue. And that is implanted, and it is replaced in time. And why is this important? This is important because you can imagine when a baby is born with a congenital disorder, so a baby that has a heart valve that does not open and close properly, the alternative is to implant a mechanical heart valve made of permanent plastic or metal. And the babies are very small. You can imagine it's already very difficult to find a valve that will fit into a heart valve of a child. But you can also imagine when a child starts growing, the heart valve does not fit anymore. So we have to do repeated surgeries every time that the child, until the age of 18, the child has to undergo a number of surgeries in order to have a valve that can fulfill its function. And that is what is different about this technique shown here, is that the idea is to stimulate at a very, very early stage, to stimulate the body to create its own tissue, and then this heart valve can actually grow with the child, so no repeated surgeries are needed. Again, also the material shown here is relatively simple. And with both of these examples, we have shown some excellent clinical successes. So the ceramic materials I showed before, based on those materials that you have here, a product has been brought into a market, and over 30,000 patients have already been treated with this product. Similarly, a product is being now clinically tested successfully has been tested in 10 children with the heart valve shown here. But heart valve and bone, that is not the most complex tissue to regenerate. Because, especially not in these patients, because these children, they are otherwise healthy and they have excellent regenerative potential. So the next challenge that we are facing is how do we develop a heart valve that is also functional and can establish regeneration of a heart valve of a 65-year-old patient who suffers from diabetes and other systemic diseases, where the regenerative potential is much less pronounced than in healthy young patients. And here, this is something that the field is very much working on, trying to change the properties of the materials that we use, trying to combine and converge technologies and chemistry and material science to develop something that will be adapted to the needs of individual patients. The same is the case for bone. I mean, bone is, again, relatively easy. If you implant it, it can stimulate the process of regeneration. But did any of you try to break the little particle that you were holding in your hand? Somebody must have tried. Because the ceramic, as I said, it's very much like a cup. If you drop a cup on the floor, it will break. And that the same will happen with the little particle, especially as you may have seen, it's very porous, it's full of holes. So you can easily squeeze it between your hands, between your fingers, and you can break it, which is very counterintuitive to use that in the bones, because bone is there to carry our weight and to help us walk. So that is exactly what would happen with those ceramic particles as well. We cannot put them in a large defect just like that and start walking immediately. We have to use the plates and the screws to fix everything until the process of regeneration is completed. But that is not regenerative medicine. We don't want that, right? We do want to offer the body something just temporarily and not work with plates and screws. And that is why we are now very much looking into improving, for example, the mechanical properties of these materials. Not having a cup that will break if you drop it, but use stronger materials that offer more flexibility in terms of mechanical properties that can actually be loaded. And also starting to combine them into a very complex tissues. For example, osteoarthritic joints, a knee joint, where both cartilage and bone are affected. So now trying to use, again, technologies like 3D printing, for example, combining different types of materials and making them such that they, in the body, can offer in the right place the right signal to complete the process of regeneration. So this is something where the field is going to, trying to develop more of these instructive materials and instructive technologies to also be able to treat this kind of more complex and difficult defects. But sometimes this is not enough, because everything that I've shown so far, it does not include any cells, does not include any growth factors, non-biological molecules. It's completely synthetic. And we like that because synthetic is usually cheap or cheaper. We do not have problems with storage. It's very easy to make it in larger quantities. But again, sometimes that is not enough. There are situations where, if we think about malfunctioning organs, kidney failure, for example, or diabetes, type 1 diabetes, for example, these are very difficult to treat by a very simple material. And in that case, we start using a patient's own cells sometimes, and we will hear probably more about that later in the lecture by Professor De Coppi. But what I will try to show here is only one example that also for this type of therapies, the technology plays a very important role. So in this animation, I'm showing something that our lab has developed in the past couple of years. And this is just, what you see here is just a regular 96 well plate. That is the plate where we can culture cells inside. And what we've done is we've modified the plate such that inside of each of these well of the plates, as you can see that here, we have created many micro wells. So inside each well, we create micro wells inside, more than 500 of them inside. So why is this important? Now we can use just a few cells from a patient, for example, and have them go into these small, tiny micro wells. And because these wells are so small, they will trigger the cells to self-assemble, to create little tiny micro tissues. So they can create a little tissues inside. And now we can treat each of these individual wells with growth factors, with biological molecules that will steer these cells to go, for example, into cartilage cells or bone cells. And because we can do that into high throughput, we can simultaneously test many and create many of these microtissues. So once we've done that, we can combine these little microtissues into larger structures, into larger forms. And we can decide how many of cartilage and how many of bone cells, microtissues we want to combine. And when they are put into a larger shape, they again start assembling. And this is what we call bottom-up tissue engineering. That is the idea is that you start with just a few cells, but by using the technology, in this case a microtechnology, you are forcing the cells into a certain direction and having them combine and self-assemble into much larger tissues. So that is shown here. So this is the example of the paper that we've published on this. And what you see here, the tissue that you see here, it's actually the mid-ear bone. But you can imagine that this can be done with many other complex tissues and organs, because you can control from bottom up, you can control the properties of the cells inside such a complex tissue, or even you can think of complex organs. So what I hope I have showed with these examples tonight is that regenerative medicine is a highly multidisciplinary field. I mentioned before I'm a material scientist. Actually, by training, I'm a chemical engineer. But the institute I'm working at, we have bioinformaticians, we have biologists, we are working with clinicians as well. We are working with people who really have the knowledge in nanotechnology and microtechnology, all working together to develop something that will be eventually beneficial for a patient. And it is very, very important to use the tools from other fields and combine them, converge these technologies together, because many of the things I've shown tonight wouldn't be possible with a single discipline. Now, looking at what I've shown tonight, although some of these treatments that I've shown tonight, they have shown some clinical successes. But from a materials perspective, the ceramic that I showed you, these little particles, they are actually very simple. It is very simple. This is just two salts that you put together and you bake them. That's what I said in the beginning. Also, the polymer for the heart valve is not really a rocket science. And actually, in our field, the advancements in the field of material science and also the technologies, they are not as far as in many other fields. So if we just look into the progress in the computer science, for example, or in any other industry, in catalysts or in other fields, the progress of material science and technology is much, much further than it is in the field of regenerative medicine or biomedical applications in general, which is a kind of surprising, right? I mean, I guess all of us would prefer a healthy body until we are 95 rather than a very fast computer, although some younger people will probably like a very fast computer right now. And the question is actually why is that? Is it because we're still not multidisciplinary enough? We still do not speak each other's language? Or is it maybe because of a matter of lack of acceptance? Because you can imagine that this ceramic, if I tell you it looks very much like a bone, then it's probably easier for both you and a surgeon to accept it as something that you will implant into the body than a microcomputer or micro pump, so micro robots that you can implant there, and you can, on a distance, you can make sure that it releases something that will complete the process of regeneration. That sounds much more like a science fiction. So that is why I think it is also something that's a mindset that I think will have to change if we want to keep making really new advancements in the field of regenerative medicine and wider than that, to really that we start accepting some very advanced technologies from other fields that may not be biomimetic, as we call them, that may not look like what we find in a body, but that actually are very effective. So last but not least, we are not newts. Unfortunately, we still, despite all the work we've invested in, we keep on investing into it, we cannot do what they can, but we are getting there. We are making a progress, and I'm really hopeful for the future that we will also, especially by employing and by accepting advanced technologies from other fields, that will make even more progress than we did so far. So with that, I would like to close and thank you very much for your attention.
Thank you, Nicola. Thank you, Pamela, for the very nice presentation that allow me to move more towards patient and what we can do into patient, because that's the territory I feel more familiar. I think we're not starting from the beginning for some reason. And I would like to thanks for the invitation tonight, and being here and attached to the Netherlands is very nice, because it goes back a few years ago. I will try to make a story out of that. But it's certainly very close to my heart, even if I'm not Dutch for some reason. I have to confess that I'm a surgeon, so everything looks good to me, particularly when I do it. The fact why I'm interested in regenerative medicine, well, I deal on a daily basis with patients that I meet when they're really born. And here is one of these patients. So this patient is born with an esophageal atresia. So difficult terminology to say that the esophagus, so the gullet that all of us have developed during the fetal life, hasn't developed on this child. So this child is put on the breast for breastfeeding and start choking and spitting. And so a nurse tried to pass a tube just to see if there's a problem. And that tube, as you see from the arrows, stops somewhere here. It doesn't go down to the stomach because the esophagus has not developed. And so in this patient now we become quite good at trying to put the gullet together. And here you see some images of this esophagus put it together by surgery. And we become so good that we now do it without even cutting. So we do it with a camera and with some small instrument. And that is my first relationship with the Netherlands. So because I learned at the AMC, which is a great institution in Amsterdam, and is one of the biggest hospital there, and I was there in 97, 98, and I learned this type of surgery really there. So that's the first relationship. But when we are not able to do that, we have to do something that is well tolerated in 80 years old with an esophageal cancer. But to do it on a child that is otherwise normal is a big thing. And essentially, we bring the stomach and we bring it up to the neck to allow this child to swallow. So his stomach, instead of being here, it being up here. So you have to imagine when it's Christmas time and you have a very nice meal, how difficult it is for that child. And his ear and yarn is having that problem. So that's why many pediatric surgeons in reality have really looked into regenerative medicine. Another example here, we are at Great Ormond Street. We are one of the centers specialized on separating conjoined twins. So these are children that are born, are conjoined, so they share some organs. This particular twin 1 and twin 2 that you see there, I'm sure for some the images are a bit distressing, but it's not finished here, so be prepared for the rest of the lecture. But essentially, you see here, the old tummy is missing, and here the other twin, the old tummy is missing because they were just joined by their tummy. So there are situations in which really we miss tissue, and we would love to have some tissue to really repair those children. So regenerative medicine is trying to do that. And actually, Pamela has very nicely introduced the field, so I don't need to speak much about that. But certainly, one of the main contribution to the field, from my perspective, has been the fact that we can now culture cells. So we can take cells from the body and we can expand them, making large numbers outside the body. And so, of course, being particularly here, you always have to look back at history. And that's the way to understand the future. And if you want to go back on regenerative medicine, you have to go back quite some years ago. And so you can decide to go back to different, of course, seminar paper. But I think I'm taking this one from 1934 or so, because it tells also a very nice story. So you may recognize being passionate about science, both names. Usually when I speak at surgeons, one is not known at all. Alexis Carrel was already very famous, and because he described how to join vessels together. So he's considered the father of transplantation, and he already received the Nobel Prize for that when he started working with Charles Lindbergh. I'm sure many here knows Charles, and he did the first solo flight over the Atlantic at about the same time. He's an engineer, he was an engineer, nothing to do with medicine, nothing to do with biology, but he had a sister with a congenital cardiac problem. So I went to Alexis Carrel and say, how is it possible that I can fly over the Atlantic and you cannot make a new heart for my sister? And as you can see, we are not there yet. But it was very interesting because this was just passion. It was not that he was a biologist, not that he was a surgeon or a medical doctor, but he had the passion because his sister was having this terrible disease. And I think this is a great teaching, particularly for the young people here, because you can be driven to do amazing stuff by passion. And he started working with Alexis Carrel on culturing cardiomyocytes in a petri dish. They started from frogs, and they were the first to describe that. So that's a nice story that goes on the back of regenerative medicine. We now move a long way from that, and there are various types of cells that can be used for regeneration. But I want to focus my attention tonight on fetal cells. Why those? Well, these are not the embryo as such, and not the cells that every one of us has here today, like in the bone marrow or in the fat, and so on. But there are cells that can be derived while the fetus is developing in the womb. And why I focus on that? Well, because most of the malformation I'm dealing with, mom and dad will know it during the gestation. So during the scan that we do before the baby is born, we know about those, or at least we suspect about. So we can take cells from the fetus and use them to make a tissue. Also because we know about those very early on in pregnancy, at about 12 weeks, 14 weeks. So we have a long time, 6 months or so, to actually prepare those tissues or those organs. So while I was in Boston, working at Boston Children's, a few years ago now, we described cells that derive from the amniotic fluid. So the amniotic fluid is sort of a fluid that surrounds the fetus during development, and we were able to describe that we could take those cells from the amniotic fluid and expand them and show some properties that are similar to stem cells. So Pamela was very nicely showing the bone ceramic. If you put some cells on this bone ceramic, and then you put it in a little mouse, you see like that. So you see this bony structure. They're a bit outside of where they should be, just because they are artificial. So we prepare those in the lab, and then we put it in mice. But actually, we can use these cells for a double use. So prior to this tonight, there was a series of lecture here on gene therapy. So you can take cells from the fetus while it's developing, genetically engineer or manipulating them, and inject it back into the same fetus. Or use it for the fetus once it's born, as I was mentioning before. And why that? Because, and there are some studies for the one that wants to have citations is that if you take cells and you inject it into the fetus to do a therapy of some genetic disease, we know now that these cells will be rejected. Why will be rejected? Because the cells that you inject into the fetus go through the placenta into the mother bloodstream. Then the mother produces antibodies and other cells that will go back into the fetus and destroy the cells that have engrafted in the fetus. So that's no way. It doesn't work like that. But there's another resource. The mother and the fetus are the perfect transplant to completely different individuals that, unless there's a disease, don't reject each other. So we thought, well, maybe we can use the cells from the fetus, take those cells, genetically engineer, so manipulating them if the fetus has a disease, and inject it back into the fetus. So of course, we're not there in human, but we have done this, and this is the team that does this work, and we took the sheep as a model. Why the sheep? Well, the sheep, for various reasons, is very similar to human in terms of the gestation. It lasts long enough, and the fetus develop in a similar way. So first we proved that, of course, in the amniotic fluid there were stem cells. And to compare in sheep, we proved that similar cells that are present in the amniotic fluid are also present in the bone marrow of the sheep, which is a classical stem cells place. So then when we proved that those cells, when injected in a mice, they can engraft, so they can colonize the bloodstream of the mice. So that's to prove that are truly stem cells. And these are just some images of the cells that you see in green because they derive from the mice that were transplanted. So then what we did, and that's very important, stem cells, because, and this allow me to talk a bit about the concept of the stem cells. So the stem cells is the cells that can differentiate in various tissues, and I think we talk a bit about this tonight, but actually it's the cells that can self-renew. So from one cell that you can give rise to multiple cells that exactly have the same property of the cells we start from. And so this is the experiments that prove that. So just bear with me. If you take the cells from a sheep and you inject in these mice, you can have cells that give rise to different tissues. But that's not enough to prove they're stem cells. But if you now sacrifice these mice and take the stem cell from these mice and inject it in a second mice, and you still find cells from the sheep, it means that the cells are truly stem cells. They're integrated in the first mice, and then they go into the second mice. And in fact, we could prove, so this is just in the blood of the second mice, and we proved that the cells are present there. So having proved that, we went back into the sheep, and we did the experiments that one day we hope to do in human, which was to take cells from the amniotic fluid and then go overnight in the lab, transducing those cells with a vector that will allow us to follow the cells, and that injected in the same lamp the day after. And then we followed the lamp until they were delivered. And interesting enough, all those lamps maintain the cells that we injected. So it means that the cells were not rejected by the lamp, neither by the mom. And most importantly, there was no cells that engraft in the mom, which make it safer eventually for clinical translation. So are we ready for clinical translation using the amniotic fluid stem cells? I mean, it would be ideal, but we are not there yet. Unfortunately, though, we have patients that suffer with congenital problems all the time. And tonight, I want to spend a bit of time to talk to you about the story of Kieran. So Kieran was born with one of these malformations, which affected his windpipe. So his windpipe was very narrow when he was born, just a few millimeter diameter. That means that it's like for us taking a straw and running 100 meters, breathing through the straw. It's the same type of feeling. So he had a series of operations to maintain his airway, so to keep his airway open, and these were mainly done by Professor Elliott, who was the chief of cardiothoracic at that time. He had a series of operations until he was 12, when he started bleeding from his windpipe, and there was nothing else that we could do. So about that time, we had a good 10 years of experience with these type of issues in animals, in the research animals. So we went through ethics and we proposed something that was never done before. And this cartoon here show you a bit what happened that day. So here is a cadaver, a donor. We took the trachea, the windpipe from the cadaver, and then using some detergent, we wash out all the cells. And this was to avoid the trachea to be rejected by Kieran. So this was stored in the fridge and ready to be transplanted into Kieran. So Kieran came to the operating theater, and stem cells were taken from his bone marrow and from his airway. And this went back to the lab to be processed and to be seated on the trachea. In the meantime, we proceed with the removal of the trachea. Admittedly, it was a bit more difficult than that, the surgery. And in the meantime, the cells were processed in the lab, and they were seeded using also some factors that will help the cell deciding what to become once put it on the trachea. And you see here that process happening. The seeding of the cells, I must admit, I didn't see it because it was in theater, but was not very different from what you see here in the cartoon. And then the trachea was moved back into the theater to be transplanted. So essentially what we've done at that time was to transplant the old trachea, removing the old trachea and putting the trachea engineered with Kieran cells back into his body. So again, move around if you want to see surgery, turn around. But here is some process of this happening, and this was the transplant of the trachea. And this is the trachea after about 6 months. So resembling almost a normal trachea. So I could spend the night here showing you physiology data and so on. I think the next slide is going to tell you more of what it's about. So here is Kieran playing his favorite instrument. And he never had to take a pill for ejection. He never had a tracheostomy. And so he's doing very well. And he's now a big adult. So it's 20 years old because this was done in 2010. And there's, of course, big debate around this. Costing. It cost about £250,000 to do this single patient. Is that ethical? Well, it's open for debate. But certainly, what we have seen is that in the subsequent year, the cost went down almost to zero because he was a normal child. So he didn't need any more our intensive care and so on. And the trachea is a bit reduced in size, of course, because he had a big spare growth from 12 to 20, but still work very well, and he doesn't have any problem with that. So, of course, we need to be very careful. We are at the Royal Institution, so we are in the right place to discuss about factors that can influence science. And one of these factors is that if we don't follow the rule, we go very wrong. So for the Lancet, we just review the experience of regenerative medicine around the world. And actually, they are bad examples. So many of you may have heard what happened in Stockholm by Paolo Macchiarini that implanted some plastic trachea. So the material that Pamela was talking about, but not tested in animals, not going through the right process, and unfortunately, there were 8 fatalities following that type of transplant. Of course, that program is being closed, big scandal, and so on, but we need to be able, as scientists, as doctors, to prevent that from happening. But equally, there's great examples. Michele De Luca and his team, and I will talk about another experience from that group at the end of my presentation. He's doing amazing stuff on cornea replacement. So cornea, if you have a burning cornea on one side for chemical or so on, now the gold standard is to take stem cells from the other eye, growing them, putting on this material, and transplant the other eye. And this now has become the gold standard. It's the best therapy around for these type of injuries. So regenerative medicine is already in patient and is already helping patient. So which other organs, and I'm continuing to give credit to the people that work in the lab, because that's, I couldn't be here talking to you tonight if it was not for them. But we have worked subsequently to the trachea on a series of organs, just to show you some. Here you see a lung that gets desolarized, so you see very pale because all the cells are gone. And you see it pumping in and out as would be a normal lung. And then if you cut that lung and you look with a microscope, you can see all the structure there down. And if you zoom in, you see all the alveoli where the gas exchange happened. They're all there. And even if you zoom more in, you see little capillary. We're talking about 3-micron capillary. They're still open. So by taking out all the cells, we don't destroy the architecture, the matrix that is there to form a new organ. Just here, the liver. Here is a rat liver, which got desolarized, but you see then we inject some dye, and it's still patent and still perfuse the old liver. But actually, we can scale it up. So we were, a few years ago, we were the first to show that we could do the same with human liver. So we can desolarize completely a human liver. And we are now trying to put the cells back into the liver. Kidney is another organ where there's really a shortage. These complex organs, however, are not easy to resolarize. So when we try that, and we try to put in animals, we fail, because those organs are getting clot, and they're not getting perfused by the blood. So another organ that we're very interesting is the gut, the intestine, and I will finish with the story of the esophagus, of course. So I'm fortunate enough to coordinate a large European grant, hopefully will not be the last, on gut tissue engineering. And again, it's another relationship with the Netherlands, with one key collaborators on this grant. He sounds clever. Is clever as name and also as fact. He is one of the brightest scientists in this field, and he works on organoids, so on little organs, as Pamela was showing to you, derived from the body, from different tissues. And one of the organs we're working together is the intestine. So we have a lot of children that are born or miss earlier on in life a large amount of their intestine, and they are fed by TPN, the parenteral nutrition, so the nutrition through the vein. In those children, we aim to take cells and then using what I showed you before on desolarized tissue to make new intestine for transplantation. So here is an intestine, and this intestine now without the cells look very transparent, but still maintain the structure. So you see here the little villi, which is the place where we will absorb our wine in the reception in a minute, and you see the crypts here where the stem cells resides. And we can do that for human as well, so no problem there. So you get very excited, the postdoc in the lab are all very excited, and then they move just around the corner to the British Museum, and they're very depressed because they were doing the same 20,000 years ago. So we're using just the derivation of these matrix to make vast. So in science, you don't invent anything, you just make it a bit better, hopefully. And one of the wildest experiences I did as a surgeon was to go down to Grenoble, where there's the accelerator. And why that? Well, I wanted to understand how these matrices are made. Because if we can understand how matrices are made, then we hopefully can make it, thanks to Pamela, in the lab. We don't need to take cadaveric organs. So I went there with physics at 2 o'clock in the morning, because you have the slot on 24 hours. So, and they did these images. I mean, they were looking at me a bit like Frankenstein, because, of course, there's the place where they study material to make bridges, to make new material, and so on. We were there with our intestine or our liver, so it looked a bit funny. But they were coming back with a lot of numbers which I couldn't understand, but I could understand images. So they were able to reconstruct all those images using the data derived from the material. And so what we could do mathematical modeling around that, reconstruct an ideal intestine, and then print it. So we could use that, and of course, for a surgeon, these two look identical. I'm sure for a scientist, not, in the sense that here is what Mother Nature has done on million years, and here, what we have tried to do with this mechanism. So you see here the villi that resemble this villi, and the crypt here that are similar to the crypts here. So, of course, we are not there yet, but we are moving in that direction, and that's the direction that hopefully will be taken. So, are we ready for more engineered organs for the patient? Of course, as a surgeon, I'm ready, but we are not there ready yet. So I was telling you at the beginning about the story of the boy that couldn't swallow because of the esophagus. So we, thanks to many, but mainly the NIHR has invested on this. We aim to take cells from the body of this little boy born without the gullet, without the esophagus, expanding those cells and putting it on esophagus, and a pig esophagus, because I will tell you in a second, the pig esophagus, once it's stripped out from all the cells, will not be rejected. And then after conditioning them in the bioreactor, trying to transplant that. So we showed a few years ago that actually, while you strip out all the cells, the matrix is so similar among species that if you use a porcine esophagus on a human body without the cells, it's very unlikely to create any rejection. So that will allow us to take a vast amount of organs that at the moment we are not able to take. So here's the pig esophagus after taking out the cells. And then here is some example of this bioreactor. Don't think of anything extraordinary. I mean, Pamela was showing you the evolution of computer and so on. I mean, in regenerative medicine, you can make those bioreactors pretty much at your home. With a nice bottle and a nice pump, you can make it, I can assure you. But essentially, what we use those is to give the esophagus here all the signaling to make that contracting. So you see here this esophagus. You may appreciate the movement here. So he's having a bit of pizza now. So let's see if he moves. Yes. So the pizza goes down the esophagus. So it's a pump that actually helps the cells educating themselves to make what they have to do once we implanted this into patient. And we can follow that. So, for example, we can take cells that express some genes, and we don't need to sacrifice this esophagus. We can follow these cells in some clever bioreactor that can tell us how the cells are doing. And, of course, we can implant those. These are animals that receive those esophagus. And I just want to show you, thanks to the team, again, at Great Ormond Street Hospital. Here are some images of those esophagus that get implanted. You see the trachea. Now we twist it around, and you see here in a minute the esophagus appearing. So this engineered esophagus we can, for now, transplant it in large animals. So you see here the section of the esophagus implanted in this way. So this is what we are aiming to do, hopefully similar to what we have done with the trachea for children that are born without part of their esophagus. So just to finish up with some messages, I mean, of course, stem cells can be derived from different tissues. They have a different capacity to proliferate, to differentiate, to give rise to different tissues, but they may become important more and more for various diseases. There are still problems, of course. We haven't solved all the problems, but the only message I want to give you tonight, that regenerative medicine is a clinical reality. And just as I was mentioning before, I want to finish with one of, I think, the greatest example of what has happened in the near future. So this a little boy you may have heard in the news that was in Germany, but actually was coming from Syria with a very difficult and terrible disease that is called epidermolysis bullosa, or EB. Essentially, all these cells was continuous exfoliating because of genetic problem. And so the skin was not staying in place, would not stay in place. So here's the child. He had to be completely sedated in the intensive care because you can only imagine about the pain of this child. So the Luca I was mentioning you before was able to take a biopsy of this child, genetically engineer, so using a vector, modifying the gene that encodes for this disease, making new cells, expanding these cells, making new skin, and implanting this new skin in the body. And you see now is a normal child with a normal skin. So again, I think I couldn't be here if it was not all the people that are working on this aspect. Of course, I need to acknowledge all the funding received for the research I presented to you. And thank you very much again for the opportunity tonight.